A 3-year-old boy presents with a 2-day history of fever, irritability, and ear tugging. Upon examination, the physician diagnoses him with acute otitis media. What are the recommended management strategies, including considerations for antibiotic therapy? Answer: acute otitis media (AOM) is commonly caused by bacterial pathogens such as Streptococcus pneumoniae and Haemophilus influenzae. Management strategies depend on the child's age, severity of symptoms, and the presence of bilateral AOM. The American Academy of Pediatrics (OP) recommends observation for children aged 6 to 3 months with unilateral AOM and mild symptoms. A period of observation without antibiotics may be appropriate. Antibiotic therapy in cases where antibiotics are warranted, e.g., children under 6 months, severe symptoms, or bilateral AOM. First-line treatment is amoxicillin 80-90 divided twice daily for 7-10 days. For recurrent cases or treatment failures, consider or maintain amoxicillin clavulanate or alternative antibiotics for resistant organisms. Pain management: administer analgesics such as acetaminophen or ibuprofen to manage discomfort. Follow-up: assess symptoms after 4-8-72 hours to determine the need for further intervention if there is no improvement. Discuss the differences in management approaches for community-acquired pneumonia (CAP) versus hospital-acquired pneumonia (HAP) in pediatric patients. Answer: the management of pneumonia in children varies significantly between community-acquired pneumonia (CAP) and hospital-acquired pneumonia (HAP) due to differences in pathogen exposure and severity. Community-acquired pneumonia (CAP) empiric antibiotic therapy. Amoxicillin is usually the first-line treatment for CAP caused by Streptococcus pneumoniae. If atypical pathogens are suspected, e.g., Mycoplasma pneumoniae or macrolide, such as azithromycin, may be added. Supportive care: this includes hydration, antipyretics, and monitoring for respiratory distress. Follow-up: reassess after 4-8-72 hours to ensure clinical improvement. Hospital-acquired pneumonia (HAP) empiric antibiotic therapy. Due to the potential for multi-drug resistant organisms, broad-spectrum intravenous antibiotics, e.g., piperacillin, tazobactam, cefepime, are often initiated. Consider coverage for MRSA, e.g., vancomycin, and Pseudomonas aeruginosa if risk factors are present. Supportive care: more intensive monitoring in a hospital setting is required, with possible respiratory support, e.g., oxygen therapy, mechanical ventilation. Culture and sensitivity testing: sputum or blood cultures should be obtained to guide antibiotic therapy based on susceptibility. A 2-year-old presents with fever, vomiting, and a bulging fontanelle. What diagnostic tests should be performed, and what are the key indicators of bacterial meningitis? Answer: in a child suspected of having bacterial meningitis, the following diagnostic tests are critical. Lumbar puncture: this is the gold standard for diagnosing meningitis. Analysis of cerebrospinal fluid (CSF) should include appearance: cloudy or turbid indicates possible bacterial infection. Cell count: a high white blood cell count equals 100 cell with a predominance of neutrophils suggests bacterial meningitis. Glucose level: low CSF glucose 100 mg/dL are typically seen in bacterial meningitis. Culture and Gram stain to identify the causative organism. Blood cultures should be obtained to detect bacteremia, which occurs in many cases of bacterial meningitis. Imaging studies: a CT or MRI may be necessary before lumbar puncture if there are signs of increased intracranial pressure or focal neurological deficits. Compare and contrast the clinical manifestations and management strategies for respiratory syncytial virus (RSV) and influenza in pediatric patients. Answer: both RSV and influenza are significant viral pathogens causing respiratory infections in children, but they have distinct clinical features and management approaches. Respiratory syncytial virus (RSV) typically presents with mild upper respiratory symptoms but can progress to bronchiolitis or pneumonia, especially in infants. Symptoms include wheezing, retractions, and difficulty breathing. Management: supportive care, hydration, and oxygen therapy are crucial for management. In severe cases, hospitalization may be required for monitoring and respiratory support. Preventive measures: palivizumab is indicated for high-risk infants to reduce the risk of severe RSV disease. Influenza: presents with sudden onset of fever, myalgia, cough, and malaise. It can lead to secondary bacterial infections and complications such as pneumonia. Management: antiviral therapy. Oseltamivir Tamiflu is effective if started within 48 hours of symptom onset. Supportive care: similar to RSV, emphasizing hydration and symptomatic relief. MS: Thompson brings her 8-year-old son, Alex, to the clinic with a 3-day history of high fever and a rash that began on his face and spread downwards. You suspect measles. What steps should you take for diagnosis and management, considering the potential public health implications? Answer: in the case of suspected measles, the following steps should be taken. Clinical diagnosis. Measles is characterized by the classic triad of high fever, cough, and conjunctivitis, followed by a maculopapular rash that typically starts on the face and spreads to the trunk. Koplik spots may also be present in the oral cavity. Laboratory confirmation. Obtain a serum sample for measles-specific IgM antibodies or a throat swab for PCR testing to confirm the diagnosis. Public health notification. Measles is a notifiable disease. Contact local health authorities to report the case and implement necessary public health measures. Management. Supportive care. Focus on hydration, fever management, and monitoring for complications such as pneumonia or encephalitis. Vitamin supplementation. Administer Vitamix oral or intramuscular to reduce the risk of complications, especially in hospitalized patients. Isolation precautions. Since measles is highly contagious, recommend isolation from non-immune individuals and provide guidance on vaccination for exposed individuals. What principles underlie antimicrobial stewardship programs in pediatric practice, and how can these programs impact the management of infectious diseases in children? Answer: antimicrobial stewardship (AMS) programs aim to optimize antibiotic use and combat antimicrobial resistance. Key principles include appropriate use of antibiotics, prescribing antibiotics only when clinically indicated, based on evidence-based guidelines to prevent misuse and overuse, selection of agents, choosing the most effective antibiotic for the specific infection, considering the local antibiogram to tailor therapy to the most likely pathogens, dosage optimization, dosing antibiotics based on the child's weight and the pharmacokinetics of the drug, ensuring therapeutic efficacy while minimizing toxicity, duration of therapy, shortening the duration of antibiotic therapy whenever possible, which is particularly relevant in cases such as uncomplicated urinary tract infections where 3 days may suffice instead of 7. Impact on management. Reduces the incidence of antibiotic-resistant infections. Improves patient outcomes by ensuring effective and appropriate treatment. Minimizes adverse effects and complications associated with unnecessary antibiotic use. Discuss the primary viral pathogens causing viral gastroenteritis in children and the recommended management strategies, including rehydration techniques. Answer: viral gastroenteritis is primarily caused by rotavirus, a leading cause of severe diarrhea in infants and young children. Vaccination has significantly reduced its incidence. Norovirus, common in older children and adults, responsible for outbreaks in communal settings. Adenovirus and astrovirus, less common but can also cause gastroenteritis. Management strategies. Rehydration. Oral rehydration solutions should be provided to replace lost fluids and electrolytes. In cases of severe dehydration, intravenous fluids may be necessary. Nutritional support. Continue age-appropriate feeding during recovery, as withholding food may prolong recovery. Breastfeeding should be continued for infants. Antidiarrheal medications. Generally not recommended for viral gastroenteritis due to potential complications. Identify key management strategies for Giardia lamblia infection in children, including diagnosis and treatment options. Answer: Giardia lamblia is a protozoan parasite causing gastrointestinal illness, particularly in young children. Diagnosis: stool examination. Microscopic identification of cysts or trophozoites in stool samples is crucial for diagnosis. Multiple samples may be necessary for confirmation. Antigen testing. Enzyme immunoassays for Giardia antigen can provide a rapid diagnosis. Management strategies. Medication. The first-line treatment is metronidazole, 50 a day divided into 3 doses for 5-7 days, or tinidazole, single dose of 2 grams for children over 12 months. Supportive care. Encourage hydration and maintain nutritional support during recovery. Follow up, monitor for persistent symptoms, and consider a treatment if necessary. What are the key components of the immunization schedule for children, and how do they contribute to the prevention of infectious diseases? Answer: the immunization schedule for children is designed to provide protection against several vaccine-preventable diseases. Vaccines. Key vaccines include MMR, measles, mumps, rubella, protects against measles, which can lead to severe complications. DTaP, diphtheria, tetanus, pertussis, provides protection against these 3 bacterial diseases. Haemophilus influenzae type B prevents serious infections such as meningitis. IPV, inactivated poliovirus, protects against poliomyelitis. PCV, pneumococcal conjugate vaccine, reduces the risk of invasive pneumococcal disease. Schedule compliance. Timely administration of vaccines as per the CDC recommendations is critical for community immunity. Delays can increase the risk of outbreaks. Monitoring and reporting. Ongoing surveillance of vaccination rates and outbreaks allows for targeted public health interventions to improve vaccination coverage. Discuss the factors contributing to antibiotic resistance in pediatric populations and the strategies to mitigate this public health issue. Answer: factors contributing to antibiotic resistance include overuse and misuse of antibiotics, prescribing antibiotics for viral infections or unnecessary prolonged courses promotes resistance, inappropriate prescribing practices, lack of adherence to guidelines, and lack of diagnostic testing can lead to incorrect antibiotic choices, transmission of resistant strains. Close contact settings, such as daycare centers, can facilitate the spread of resistant organisms. Mitigation strategies, antimicrobial stewardship programs. Implementing AMS programs in healthcare settings to optimize antibiotic prescribing and usage. Public education, raising awareness about the appropriate use of antibiotics among parents and caregivers to reduce demand for unnecessary prescriptions. Infection control practices, enhancing hygiene and infection control measures in healthcare facilities and community settings to prevent the spread of resistant organisms. How should the approach to history taking differ when assessing a toddler compared to an adolescent? Answer: when assessing a toddler, such as a 3-year-old child, it is crucial to adopt an age-appropriate approach that considers the developmental stage. Young children may have limited verbal skills, making it challenging for them to articulate their symptoms or experiences. Thus, the caregiver, often a parent, becomes the primary source of information. Engaging the child during the conversation can help alleviate anxiety and promote cooperation. Clinicians should use simple language, ask direct questions, and incorporate play into the interaction. For example, using toys to demonstrate a procedure or asking the child to point to areas of discomfort can facilitate communication. Observing the child's nonverbal cues, such as body language, facial expressions, and general demeanor, can also provide valuable insights into their emotional state and physical well-being. In contrast, when assessing an adolescent who may be 14 years old, it is vital to foster a more open and confidential environment. Adolescents are often more capable of articulating their concerns and symptoms, but may be hesitant to discuss sensitive topics due to embarrassment or fear of judgment. Clinicians should encourage open dialogue by establishing rapport, ensuring privacy, and validating the adolescent's feelings. This age group often requires discussions around psychosocial factors, peer relationships, and mental health, which may significantly impact their overall health. What is the significance of plotting a child's growth on a growth chart, and how should one interpret percentiles? Answer: growth charts are essential tools in pediatrics, allowing healthcare providers to monitor a child's growth over time and compare it with standardized growth patterns. The significance of using growth charts lies in their ability to identify potential growth abnormalities early on. For instance, if a 6-month-old infant has weight and height plotted in the 10th percentile, it suggests that they are smaller than 90% of infants their age, potentially indicating underlying health issues. Conversely, an infant in the 90th percentile for weight may be at risk for obesity if trends continue. Interpreting percentiles involves understanding that they are not absolute indicators of health, but rather relative measures. A child consistently following a specific percentile curve may be healthy, whereas significant fluctuations, such as a drop from the 50th to the 10th percentile, can be cause for concern, potentially indicating nutritional deficiencies or medical conditions. Moreover, the child's growth should be interpreted in conjunction with other developmental milestones and health assessments, ensuring a holistic understanding of their well-being. The CDC recommends using the 2000 CDC growth charts, which provide age and sex-specific data, facilitating accurate assessments of growth trajectories. In the case of a pediatric patient presenting with fatigue, what laboratory tests would be appropriate and what interpretations might be made from abnormal results? Answer: when evaluating a pediatric patient presenting with fatigue, a comprehensive assessment should begin with a complete blood count (CBC), as it provides critical information about the child's hematologic status. For example, a 7-year-old child exhibiting fatigue and a CBC revealing anemia, low hemoglobin, and microcytic red blood cells suggests iron deficiency anemia, a common condition in this age group. The microcytic nature of the red blood cells indicates that they are smaller than average, a characteristic finding in iron deficiency. In addition to the CBC, other relevant tests may include serum ferritin and transferrin saturation levels to confirm iron deficiency. If the results indicate low ferritin levels, This suggests depleted iron stores, corroborating the diagnosis. The American Academy of Pediatrics guidelines recommend that children with iron deficiency anemia receive appropriate iron supplementation and dietary counseling to enhance iron intake through food sources like red meat, beans, and fortified cereals. Furthermore, normal results in electrolyte panels, liver function tests, LFTS, or renal function tests can provide insights into other underlying health issues. For instance, abnormal LFTS may suggest hepatic pathology, while derangements in renal function could indicate dehydration or other systemic problems. Overall, interpreting lab results must be done in conjunction with the clinical history and physical examination findings to formulate an appropriate management plan. How should one decide which imaging modality is most appropriate for evaluating suspected appendicitis in a pediatric patient? Answer: when evaluating suspected appendicitis in a pediatric patient, selecting the appropriate imaging modality is crucial for accurate diagnosis while minimizing exposure to radiation. For example, in a 10-year-old child presenting with abdominal pain, fever, and vomiting, a careful assessment of the clinical presentation must precede imaging. Initially, an abdominal ultrasound is often the first-line imaging technique in children due to its safety, lack of ionizing radiation, and high sensitivity for detecting appendicitis. Ultrasound can help visualize an enlarged, non-compressible appendix and assess associated findings such as free fluid or abscess formation. The American College of Radiology (ACA) and the Radiological Society of North America (RSNAI) recommend ultrasound as the preferred modality in children when appendicitis is suspected. If the ultrasound is inconclusive or if the clinical suspicion remains high, a computed tomography (CT) scan may be utilized, particularly in older children and adolescents. While CT scans offer superior sensitivity and specificity for diagnosing appendicitis, they involve exposure to radiation, which is a consideration in the pediatric population. In certain cases, magnetic resonance imaging may be employed for specific clinical scenarios, such as in pregnant adolescents or when avoiding radiation exposure is critical. Ultimately, the decision regarding imaging should involve an assessment of the child's age, clinical symptoms, and previous imaging results. Collaborative discussions among healthcare providers, including pediatricians and radiologists, are essential to ensure the best outcome for the child while adhering to established guidelines for pediatric imaging. What are the key components to consider when interpreting a CG in a pediatric patient, and how does this differ from adult interpretation? Answer: interpreting an electrocardiogram in a pediatric patient requires an understanding of age-related variations in heart rate, rhythm, and morphology. In children, normal resting heart rates are generally higher than in adults, with infants averaging between 100 to 160 beats per minute, while toddlers may range from 90 to 150 beats per minute. Therefore, it is essential to consider age-specific norms when evaluating an ECG. Additionally, pediatric patients may present with various normal variants that differ from adult norms. For instance, a right axis deviation can be normal in infants due to the anatomical position of the heart, whilst segment changes can also occur more frequently in children without underlying pathology. The presence of a sinus arrhythmia, characterized by variations in heart rate with respiration, is commonly seen in children and can be misinterpreted as pathological if the clinician is unaware of this age-related phenomenon. Moreover, pediatric ECG interpretation must account for congenital heart disease, which is prevalent in this population. Conditions such as Wolff-Parkinson-White syndrome or long QT syndrome can be detected on an ECG and warrant further evaluation. As such, clinicians should correlate ECG findings with clinical symptoms and utilize age-appropriate reference ranges to arrive at a diagnosis. What are the advantages and limitations of point-of-care testing (POCT) in a pediatric setting? Answer: point-of-care testing (POCT) offers several advantages in pediatric settings, particularly in emergency and primary care. One significant benefit is the rapid turnaround time, which allows for immediate clinical decision-making. For instance, a child presenting with suspected influenza can be tested using a rapid antigen test, providing results within minutes. This immediacy can facilitate timely treatment initiation, such as antiviral therapy, and enhance patient satisfaction. Another advantage of POCT is its ability to reduce the need for laboratory processing, which can be particularly beneficial in resource-limited settings or during peak times in emergency departments. Additionally, POCT can empower healthcare providers to perform diagnostic testing at the bedside, improving the overall patient experience and efficiency of care. However, limitations exist in the use of POCT. One concern is the potential for decreased accuracy and reliability compared to traditional laboratory testing. False positive or false negative results can occur, leading to misdiagnosis or inappropriate treatment. Therefore, clinicians must understand the specific test's sensitivity and specificity to interpret results appropriately. Moreover, POCT may not provide comprehensive diagnostic information, which can be crucial for more complex conditions requiring multiple tests for an accurate diagnosis. The AAP recommends using POCT as a complementary tool rather than a standalone diagnostic method, emphasizing the need for confirmatory testing when appropriate. What are the implications of abnormal laboratory findings in a pediatric patient, and how should they guide further evaluation? Answer: abnormal laboratory findings in pediatric patients can have significant implications for diagnosis and management. For example, if a 12-year-old presents with elevated liver enzymes E, G, AST, and ALT that may indicate potential liver pathology, such as hepatitis, fatty liver disease, or drug-induced liver injury, the clinician must consider the child's clinical history, including any recent illnesses, medication use, or exposure to hepatotoxic substances, to guide further evaluation. In addition to assessing abnormal results, it is essential to contextualize them with clinical symptoms and physical examination findings. Elevated white blood cell counts may indicate infection or inflammation, but without accompanying symptoms, the findings may require further investigation to rule out other conditions. Further evaluation may involve additional laboratory tests, imaging studies, or referrals to specialists depending on the clinical scenario. For example, if the initial tests raise concern for autoimmune liver disease, serologic markers such as anti-smooth muscle antibodies or anti-nuclear antibodies may be ordered to aid diagnosis. Additionally, the abnormalities may necessitate close monitoring and follow-up. For instance, persistently elevated blood glucose levels may indicate the need for further assessment to rule out diabetes mellitus. The AAP highlights the importance of a thorough evaluation of laboratory findings, emphasizing that abnormal results should prompt a comprehensive approach to ensure timely diagnosis and appropriate management. How do family dynamics influence pediatric health outcomes, and what role should healthcare providers play in addressing these dynamics? Answer: family dynamics significantly influence pediatric health outcomes, as the family unit serves as the primary support system for children. Factors such as parental mental health, socioeconomic status, and familial relationships can directly impact a child's physical and emotional well-being. For instance, children raised in households experiencing conflict or instability may be at higher risk for anxiety, depression, and behavioral issues. Conversely, supportive family environments can foster resilience and promote healthy lifestyle choices. Healthcare providers play a crucial role in addressing family dynamics by engaging families in discussions about their health and well-being. This includes exploring the family's socioeconomic conditions, living environment, and parental stresses, all of which can affect a child's health. Providers should adopt a family-centered care approach, which involves actively involving family members in the healthcare decision-making process and recognizing their impact on health outcomes. Additionally, healthcare providers can provide resources, education, and referrals to support services such as counseling or social services to address family issues that may affect health. Regular screenings for family stressors, mental health concerns, and social determinants of health can help identify at-risk families early, allowing for timely interventions. What screening recommendations are essential for pediatric patients, and how do they contribute to preventative health? Answer: screening recommendations for pediatric patients play a vital role in preventive health and early detection of potential health issues. The AAP and the U.S. Preventive Services Task Force are to provide guidelines for routine screenings that vary by age and risk factors. For example, regular screenings for developmental milestones should occur at child visits, particularly during the first 3 years of life. Identifying developmental delays early can lead to timely interventions, enhancing outcomes in areas such as speech, language, and motor skills. In addition to developmental screenings, other essential screenings include immunizations to protect against vaccine-preventable diseases, which are crucial for maintaining public health. Blood pressure screening is also recommended starting at age 3, with routine checks for obesity using BMI percentiles. Early identification of overweight or obesity can facilitate lifestyle modifications and prevent chronic diseases such as diabetes and hypertension. Screening for mental health concerns is increasingly emphasized, with the AAP recommending annual screenings for depression starting at age 12. Addressing mental health issues early can lead to improved emotional and behavioral outcomes. What factors must be considered when prescribing medications to pediatric patients, and how do they differ from adult considerations? Answer: when prescribing medications to pediatric patients, several critical factors must be considered to ensure safety and efficacy. One of the most significant differences between pediatric and adult pharmacology is the variation in drug metabolism and pharmacokinetics due to developmental differences. Neonates and infants, for example, metabolize drugs differently than older children and adults, leading to altered dosing requirements. Factors such as body weight, age, organ function, and the maturity of metabolic pathways can all influence how a child processes medication. For instance, the renal and hepatic functions of a young child may not be fully developed, necessitating adjustments in dosing to prevent toxicity. Clinicians must utilize weight-based dosing calculations for medications, which are standard practice in pediatrics, and refer to pediatric-specific dosing guidelines. Furthermore, adherence to medication regimens can be more challenging in younger populations due to developmental stage, cognitive ability, and the taste or form of medication. The use of child-friendly formulations, such as liquids or chewable tablets, can improve adherence. In addition to these pharmacokinetic considerations, healthcare providers must also evaluate the potential for adverse effects that may differ from those observed in adults. Pediatric patients may experience unique side effects or reactions, which necessitate careful monitoring and follow-up. Ultimately, a thorough understanding of pediatric pharmacology, attention to individual patient factors, and ongoing education about safe prescribing practices are crucial for optimizing medication therapy in children. The AAP encourages healthcare providers to remain informed about the latest research and guidelines in pediatric pharmacotherapy to ensure the best possible outcomes. What are the key components of the primary and secondary survey in pediatric trauma assessment, and how do they differ from adult trauma assessment? Answer: the primary survey in pediatric trauma assessment follows the ABCD approach. Airway assess patency and ensure adequate oxygenation. Children may require different approaches to airway management due to anatomical differences. Breathing: evaluate respiratory effort and adequacy. Consider the need for supplemental oxygen or ventilation support. Circulation: check pulse, blood pressure, and capillary refill. Hypotension in children can be a late sign of shock. Assess for signs of shock early. Disability: conduct a quick neurological assessment. APU: alert verbal pain unresponsive. Exposure: fully expose the patient while maintaining normothermia to assess for hidden injuries. The secondary survey involves a thorough head-to-toe examination and history taking, including mechanism of injury and potential comorbidities. Differences from adult assessment include anatomical differences. Children have a larger head-to-body ratio, which affects airway management. The physiological differences: pediatric patients may compensate for shock longer than adults, masking true severity until late in the presentation. Relevant guidelines include the Advanced Trauma Life Support (APLS) principles adapted for pediatric care. Describe the management steps for a child presenting with status epilepticus. Answer: management of status epilepticus in children includes the following steps: ensure safety, protect the child from injury during the seizure, establish IV access. If not already done, establish intravenous access for medication administration. Administer benzodiazepines. First-line treatment includes intravenous lorazepam 0.1 mg up to 4 mg or diazepam 0.15 mg up to 10 mg. Loading dose of antiepileptic. After initial treatment, consider loading dose of an anticonvulsant like fosphenytoin or levetiracetam. Continuous monitoring. Monitor vital signs, glucose levels, and potential causes of seizures, e.g. infection, metabolic disturbances. Consider intubation. If the child does not respond or continues to have seizures, intubation and the use of anesthesia may be necessary. Guidelines for the management of status epilepticus are based on the National Institute for Health and Care Excellence (NICE) and the American Epilepsy Society. Mr. Thompson brings his 5-year-old son to the emergency department due to difficulty breathing and wheezing after playing outside. What should Mr. Thompson expect during the management of his son's asthma exacerbation? Answer: Mr. Thompson should expect the following management steps for his son's asthma exacerbation. Initial assessment. The child will undergo thorough assessment, including oxygen saturation monitoring and auscultation of lung sounds. Bronchodilator therapy. The first-line treatment will likely include a short-acting beta-agonist such as albuterol. Administer via a nebulizer or metered-dose inhaler with a spacer. Oxygen therapy. Supplemental oxygen may be provided if the child's oxygen saturation is below 92%. Systemic corticosteroids. If the exacerbation is moderate to severe, oral or intravenous corticosteroids, e.g. prednisone, may be initiated to reduce inflammation. Continuous monitoring. The child will be monitored for response to treatment, including improvement in wheezing and respiratory effort. Education. Mr. Thompson will receive education on recognizing asthma triggers and the importance of follow-up care with a pediatrician for asthma management. Explain the principles of fluid resuscitation in pediatric patients experiencing hypovolemic shock. Answer. Fluid resuscitation in pediatric patients with hypovolemic shock involves assessment. Initial assessment of the child's clinical status, including vital signs, mental status, and perfusion, capillary refill time, skin temperature, type of fluid. Isotonic fluids, such as normal saline or lactated Ringer's solution, are preferred for initial resuscitation. Initial bolus. Administer an initial bolus of 20 mg of isotonic fluid and reassess hemodynamic status after each bolus. Reassessment. Continuous reassessment is critical. Signs of effective resuscitation include improved heart rate, blood pressure, and urine output. Ongoing needs. Based on the ongoing evaluation, additional fluid boluses may be needed or further evaluation may be required to identify sources of fluid loss. Guidelines from the Pediatric Advanced Life Support PALS course emphasize the importance of early and aggressive fluid resuscitation in the pediatric population, given their limited intravascular volume. What are the critical considerations in managing anaphylaxis in children? Answer. Management of anaphylaxis in children requires prompt recognition and intervention. Immediate administration of epinephrine. The first line of treatment is intramuscular epinephrine 0.1 mg, max 0.3 mg per dose given into the anterolateral thigh. This should be repeated every 5 minutes as needed. Positioning. Lay the child flat with their legs elevated to enhance venous return unless respiratory distress or vomiting occurs. Oxygen support. Provide supplemental oxygen if the child is hypoxic. Airway management. Be prepared to secure the airway if the child has significant respiratory distress or swelling. Follow-up treatment. After initial management, the child may require additional medications such as antihistamines and corticosteroids. Observation. Monitor the child in a healthcare setting for at least 4-6 hours after the last episode of anaphylaxis due to the risk of biphasic reactions. Relevant guidelines include those from the American Academy of Pediatrics and the National Institute of Allergy and Infectious Diseases. Discuss the appropriate steps in the management of a child with suspected toxic ingestion. Answer. Management of a child with suspected toxic ingestion includes initial assessment. Conduct a rapid assessment of the child's vital signs and consciousness level. Identify the substance ingested if possible. Decontamination. If the ingestion is recent and the child is alert and able to protect their airway, activated charcoal may be administered, typically 1 gram. Specific antidotes. Administer specific antidotes if indicated, e.g. N-acetylcysteine for acetaminophen overdose, naloxone for opioid overdose. Supportive care. Provide supportive care, including intravenous fluids for hydration and monitoring of vital signs. Consult toxicology. Involve a poison control center or pediatric toxicologist for guidance on management and potential complications. Transport. If necessary, consider transport to a specialized facility for further management. Guidelines are informed by the American Academy of Pediatrics and the American Association of Poison Control Centers. What are the signs and symptoms of pediatric head trauma that necessitate immediate imaging and intervention? Answer. Signs and symptoms of pediatric head trauma requiring immediate imaging and intervention include altered consciousness, any change in level of consciousness including confusion, drowsiness, or unresponsiveness, severe headache, a sudden severe headache that differs from previous headaches, persistent vomiting, repeated vomiting after the injury, seizures, any seizure activity following the head trauma. Focal neurological signs, presence of weakness, numbness, or changes in speech or coordination, pupillary changes, asymmetry in pupil size or reaction to light, cerebrospinal fluid leakage, presence of clear fluid from the nose or ears indicative of possible skull fracture, immediate imaging with a CT scan is often indicated based on the presence of these symptoms to assess for intracranial hemorrhage or skull fractures. A child presents with severe abdominal pain, vomiting, and a palpable mass in the right lower quadrant. What are the differential diagnoses and what is the appropriate next step in management? Answer. Differential diagnoses for this clinical presentation include appendicitis, the most common cause of acute abdomen in children characterized by inflammation of the appendix, intussusception, a condition where a segment of the intestine telescopes into an adjacent segment, often presenting with abdominal pain, vomiting, and a current jelly stool, mesenteric lymphadenitis, often secondary to a viral infection, presenting with similar symptoms, volvulus, twisting of the bowel, which can lead to ischemia and requires surgical intervention, The appropriate next step in management is to obtain an abdominal ultrasound or CT scan to confirm the diagnosis and determine the need for surgical intervention, particularly for appendicitis or intussusception. What are the key considerations for managing a pediatric patient with burns, and how does the management differ from adult burn care? Answer: key considerations for managing burns in pediatric patients include: assess burn depth. Classify burns into superficial, first degree, partial thickness, second degree, and full thickness, third degree, based on depth and appearance. Fluid resuscitation. Pediatric patients have a higher risk of fluid loss. The Parkland formula can be used. Total fluid requirement ml, formux body weight, AG sperm percentage. Administer half of the total volume in the first 8 hours and the remainder over the next 16 hours. Infection prevention. Monitor for signs of infection and apply topical antibiotics to prevent secondary infections. Pain management. Utilize appropriate analgesics, including opioids for severe pain. Psychosocial support. Address the emotional and psychological impact of burns on children and their families, which may require multidisciplinary support. Differences in management from adults include the consideration of growth and development stages and the importance of involving child life specialists to help manage anxiety and fear related to hospitalization and treatment. Explain the role of pediatric advanced life support (PALS) protocols in the management of pediatric emergencies and outline the key components. Answer: Pediatric Advanced Life Support (PALS) protocols play a critical role in managing pediatric emergencies by providing structured guidelines for assessment and intervention. Key components include early recognition. Prompt recognition of respiratory or cardiac arrest is essential for survival. High-quality CPR. Emphasize high-quality cardiopulmonary resuscitation (CPR) with an emphasis on chest compressions and minimizing interruptions. Airway management. Secure and maintain the airway with techniques appropriate for the child's age, including bag mask ventilation and advanced airway management if necessary. Defibrillation. Utilize appropriate defibrillation for shockable rhythms, e.g. ventricular fibrillation, using a pediatric-specific dose or settings. Post-resuscitation care. Following successful resuscitation, ongoing assessment and stabilization are crucial, including managing potential complications and monitoring for neurological status. Guidelines are based on the American Heart Association (PALS) guidelines, which emphasize the importance of effective teamwork and communication during emergencies to improve outcomes.